Again, good morning. I'd like to start with the learning objectives. I hope I have it here. Mhm. Can you see my shared screen, learning objectives?
Yes po, sir.
Can you see it, Atea?
Yes po, sir.
So demonstrate and apply principles and approaches in the diagnosis and management of common OPD surgical diseases. So for today, we'll be tackling the breast patient. Okay. So, but this patient, as I was told, this was already an inpatient, right? Okay. Anyway, she started from the outpatient going inpatient naman. Okay. So you have to demonstrate and apply the principles and approaches in performing a focus history, perform a focus physical examination, use and interpret diagnostic procedures and results, and formulate a management plan. Okay. At year level 5, no. So we try to progress to a more focused problem-solving decision-making already. No? Okay. So we should probably, we have to shift now, okay? Because the traditional ones are more expensive, more detailed, and at times they are not really efficient. No? Okay. So this is what is usually being done in clinical practice, in actual clinical practice. Everything is focused. No? Okay. Only the relevant ones are considered. No? Okay. But the outcome will be the same. No? Accurate diagnosis and probability of correct decision-making, problem-solving decision-making. Okay. So are we clear on these learning objectives? Yes? Okay. So let's, okay, I know you prepared a PowerPoint or a slide presentation. Okay. Sorry for the last minute adjustment. No, we have to undergo this last minute adjustment because of the conditions. Okay. I was not informed well ahead of time that I'm still your preceptor this morning. Okay. But I beg off 3 weeks ago. I said I'm not around. I thought they would make a substitute for me. No? But since I was surprised Kenneth PM me, so I have to make a judgment right away, decision making, problem solving, and then accommodate you before I leave from my airport. No? Okay? So since you prepared a slide presentation para hindi masayang yung presentation ninyo, can you just present this? I'll just ask questions. I'll take down notes, then ask questions later on. Okay? Is that okay?
But we're gonna follow naman po the algorithm you sent. Okay.
Yeah, that's good. That's good. No? Just try your best. No?
Can everyone see my screen?
Yeah.
Okay. So good morning, everyone. We're gonna present our case on breast cancer. Okay, so start with the case information. We had our interview yesterday. Okay, so the general data of the patient, initials are MN. She's a 45-year-old female from Santa Ana, Manila. She's currently unemployed. She's Catholic, and her chief complaint was a breast mass. So here's the history of present illness. So 4 years prior to consult, the patient felt a non-tender pulsating mass in the lower left quadrant of the left breast with an intermittent pain with severity 5/10. Then 3 years prior to consult, the patient noticed skin changes such as drying, hyperpigmentation, and ulcerations overlying the breast mass and continuing enlargement of the breast mass. These were associated with bleeding and foul-smelling discharge, and the pain episodes would have a severity ranging from 5 to 10 out of 10. And the worst is described as a stabbing pain radiating to the back. In the following months, the lesions erupted into an irregularly shaped whitish nodular soft tissue mass oozing with pustular and serous discharge with numerous ulcerations. In the interim, the patient was not able to seek consult due to the pandemic, despite worsening of symptoms. She also began to notice gradually increasing nodules in her left axilla. The patient took celecoxib, paracetamol, and tranexamic acid on the advice of a pharmacist. The patient would clean her skin lesions using boiled bayabas leaves. One year prior to consult, the patient sought consult in PGH and was diagnosed with breast malignancy. A biopsy, mammogram, and breast ultrasound were conducted, and the mass was initially measured to be 13 by 16 centimeters, and biopsy findings revealed the patient was ERPR positive and HER2 negative. Bone scan, liver ultrasound, 2D echo, and chest x-ray revealed unremarkable findings. And 10 years prior to consult, the patient begins chemotherapy of AC times 4, doxorubicin and cyclophosphamide, and T times 4 paclitaxel. Following the AC times 4, the patient noted a marked decrease in size of the breast mass to 4 by 7 centimeters and left axillary adenopathy. There was a complete resolution of pain and partial resolution of skin lesions. However, she noted side effects of hair loss, anorexia, nail changes, vomiting, and marked sensitivity to odors. At present, the patient is ambulatory, awake, and not in cardiorespiratory distress. She is currently admitted for pre-op management of MRM. Then past medical history, no comorbidities or previous hospitalizations or ER consults, but she had an elective myomectomy and PGH in 2018 and takes vitamins. Family medical history, the mother had the breast malignancy, but unstage and no biopsy. Also hypertension and type 2 DM. Sister also had hypertension, and the maternal aunt also had breast cancer at age 52. Then for personal and social history, she's an occasional alcohol drinker without any other vices. She's single and lives with and supported by parents. She's a college graduate and has been unemployed since COVID. And for sexual history, she had her coitarch at 30 years old with one sexual partner with no history of STIs. Then menstruals are irregular, lasting 5 to 7 days, soaking 2 to 5 pads a day with no dysmenorrhea. Her LMP was in October 2022, but menses stopped with chemotherapy, and she is nulliparous with an obstetric score of J0P0. For immunization history, she had complete EPI immunization, COVID vaccine, and anti-tetanus. Then for review of systems, she noted vision problems. She's nearsighted. Change in stool characteristics from firm to wet with 2 bowel movements per day, and arthralgia in the middle finger, right PIP, DIP, right knee, which worsens on prolonged standing and sitting. And vital signs are normal, but for anthropometrics, she has a BMI of 29.3, which is obese class 1 based on the WHO Asia Pacific classification. And for physical examination, the breasts are asymmetrical. The right breast is pendulous with more volume than the left. And then in the left, there's a healing ulcer with peripheral black crusts overlying a well-defined, firm, non-mobile, irregularly shaped 5.7 cm mass located in the 4 to 8 o'clock position with hyperpigmentation surrounding the lesion. And the nipple has a bumpy, dark-colored crust with no discharge. Other PE findings are unremarkable. Okay, let's start with the clinical diagnosis. So this is the first part of the algorithm. We use the signs and the symptoms to determine our primary and secondary diagnosis. So here are the important points in the history that I mentioned earlier. There was a presence of a breast mass that continuously enlarged, and she was eventually diagnosed with breast malignancy and PGH. And then there were also changes in breast appearance. Skin changes include drying, hyperpigmentation, and ulcerations overlying the breast mass. And eventually they would ooze with pustular and serosanguinous discharge. There's also breast pain, initially the severity of 5/10, which worsened to 10/10, described as stabbing and radiating to the back. Then the patient also underwent chemotherapy with doxorubicin, cyclophosphamide, and paclitaxel. Also experienced a couple of side effects like vomiting, fatigue, pruritus, and the like. And she had good response to the chemotherapy naman. There was a decrease in the size of the breast mass and left axillary adenopathy and resolution of pain and skin lesions. The patient also has several risk factors, including age. She's 45 years old, although the incidence increases, especially at 50 years old. She's also female, and most breast cancers occur in women. She is nulliparous, and I read that reproductive milestones include that increase women's lifetime estrogen exposure increase the risk of breast cancer. And she's also an occasional alcohol drinker. And then for family history, the mother had breast malignancy as well, and the maternal aunt was diagnosed with breast cancer. And first-degree relatives of patients with breast cancer have a 2 to 3-fold excess risk for developing the disease. And then for the physical exam, pertinent findings are the 29.3 BMI, which indicates obese class 1. And again, the breast and skin changes, including asymmetry and hyperpigmentation and the presence of the irregularly shaped mass and matted lymph nodes. Next, we're gonna discuss our primary and secondary diagnosis. But first, let's discuss if the case is benign versus malignant.
So when we're dealing with case, we take into consideration, of course, the signs and symptoms to build upon our clinical diagnosis. So when we found our patient, the first thing she actually noticed was a breast mass that had episodes of pain. And so when we take a look, when we first see that type of case, we're sort of thinking already, we need to check if it's benign or malignant. And then if we can look at this table, we have different particular findings that would point more to a benign lump or more to a malignant lump. So for our case, we can see that when we saw her in the OPD, with her present condition, we're looking more into a malignant lump. So we have the hard consistency, though there is painful, so it's benign. For the malignant, we have the hard consistency, irregular edge, fixation to the skin, having skin involvement, and we have that first, those parts. And then, so at that point, we're already leaning towards malignant. However, we cannot completely rule out benign. So can we have the next slide? So given that, the first our primary clinical diagnosis would be breast cancer. Sorry, the numbers there, the certainty there, actually just my notes. Let's not take into consideration the certainty percentage yet. Okay, so for breast cancer, if we're gonna take a look at the patterns that we were able to go through with Doc's lecture. So we have pattern recognition or prevalence. So for breast cancer, when we take a look at the patient's high risk, that actually makes a high risk of having a family history of breast cancer for one immediate family member, her mom, and then also her maternal aunt. that actually increases the risk. So when we look at the prevalence, the risk doubles if you have two family members who have breast cancer. When you take a look at all of the other pattern recognition, not with the characteristic of the lump, we have her other risk factors such as her being nullipara and obese. We can see the skin changes present in the form of the ulcerative lesion. We have the involvement of the axillary lymph nodes and the characteristic of the palpable breast mass. We can see that a lot of it actually can fall under the diagnosis of breast cancer. So another thing that we can consider is also Paget's disease of the breast or the nipple. So in terms of pattern recognition, also we can see that the patient had a crusty or thickened plaque-like lesion over the nipple, and that also includes nipple discoloration. In terms of prevalence, wala akong masyadong nahanap na actual percentage, but from what I read, when you'd have Paget's disease of the nipple, it's almost 88% related to a case of underlying malignancy. But then also we didn't see typical signs in Paget's, which is like the nipple discharge and also the pruritus, since it mimics the eczema of the nipple. Okay, next slide. So though when we saw the patient, it was sort of, or there's a lot of signs and symptoms already pointing to a malignancy, there's also still the possibility that we're wrong, diba? Kasi uncertain naman yung medicine. So for the secondary diagnosis, it could also still be, as I mentioned, we can't completely rule out benign yet if we're just looking at it clinically. So it can also be a benign breast mass. And then since when we look at the case, yun nga, medyo the breast mass was already big. Her first measurement was already 13/16 in her first consult back in September. And then there's also the skin involvement and also ulcerative lesion. So I was trying to look for a breast mass that could present a benign breast mass that could present as this. So that's why there's to consider that's the giant fibroadenoma. Yes, but oh sorry, okay. So that one for that, the points for that, the signs and symptoms that point more to a giant fibroadenoma are the size of the breast mass, the particular skin involvement that we saw. However, I did put it as a secondary diagnosis because there are signs and symptoms such as the axillary lymphadenopathy and the age of the patient, which is already 45, that really points more to a malignant case rather than a benign case. So for this, if I were to reevaluate, I wouldn't be confident enough to just go with the primary diagnosis. And so I'd still recommend the going through the paraclinical diagnostic tests. So if ever I'd put a number, it wouldn't reach 90, where I'm very, very certain. Baka 85 or around that range where the possibility is very high, but not fully confident that you're going to forego diagnostic tests. So I think given that, the next discussion would be which diagnostic tests. Oh, sorry, can we go to the next slide? So first, we're going to discuss the pathology. Sorry.
To support the primary and secondary clinical diagnosis.
Okay, so we'll discuss a bit about the pathophysiology of breast cancer, which is our primary consideration naman in this case. So breast cancer represents around the 15% of all new cancer cases in the Philippines and 8% of cancer-related deaths in the Philippines as well. And as we know, it's a hormone-dependent disease wherein it's thought that an increased exposure to estrogen can also be associated with increased risk for developing breast cancer. As such, as mentioned a while ago, we have important risk factors for this type of cancer, which would be being a female, the patient's age, lifetime exposure to estrogen, genetic inheritance, and also environmental and some lifestyle factors. So in general, breast cancer arises quite similarly naman to other cancers wherein there's a stepwise acquisition of driver mutations in the affected cells that eventually leads to a precursor lesion and can eventually transform into malignancy. However, I think in breast cancer, what's unique is we consider the mutations in the breast epithelial cells, and then there's also a strong genetic component. So as mentioned a while ago, we said the risk factor was genetic inheritance, and in particular, it's believed that like a quarter or a third of breast cancers occur due to the inheritance of susceptibility genes. So these can be low penetrance or high penetrance, and the most studied ones are mutations in BRCA and BRCA2. So the two most investigated genes, and most carriers of these genes often develop breast cancer by the time they're 70 years old. So as you can see in the diagram, from a normal breast, if the patient has a familial predisposition for breast cancer and they have a BRCA2 mutation, it usually ends up it's more associated with the luminal type of breast cancers, whereas patients with a familial predisposition for breast cancer and possessing a BRCA1 mutation, it often is more associated with a triple negative breast cancer. But if the patient doesn't have a familial predisposition for cancer, usually how does a breast cancer arise? So there are three major, parang how they divide breast cancer would be into three types, and then they follow certain pathways. So the major pathway and the most common one would be the ER positive pathway, wherein this is mostly regulated by estrogen, since estrogen regulates the pattern of gene expression in this type of subtype of breast cancer. So estrogen promotes the local production of growth factors and the proliferation of breast epithelial cells. And when this happens, it increases the pool of cells that are also at risk for transformation. And when there is defects in DNA repair, or there are problems in replication and cell division, these can eventually lead to the accumulation of mutations that can present firstly the precursor lesions. So in the luminal type of cancer, the flat epithelial atypia and atypical ductal hyperplasia are two of the more common precursor lesions. However, there are more events that are still needed in order for it to fully become a malignant lesion. And then on the flip side, if we have an ER positive pathway, we also have an ER negative pathway. And this pathway is less common, and it's thought to be attributed to defects in DNA repair and genomic instability associated with BRCA1 mutation that eventually leads to a triple negative cancer, meaning ER negative and HER2 negative as well. Lastly, the third subtype would be the HER2 positive pathway. So this often arises due to an overexpression of the HER2 gene through HER2 amplification. And while there's no definite or signature precursor lesion, it still also eventually leads to a malignancy. Okay, so if we recall from our history, parang we mentioned our patient is ER positive and HER2 negative, so it's more likely na the patient has a luminal type of cancer. Okay, so that's all for our discussion for the pathophysiology. I think our next would be diagnostics.
Thank you, Jade. Okay, so our next part is the paraclinical diagnostic procedures. Okay, so it's this part, the indication, selection, and interpretation. And first, we have to restate our primary and secondary clinical diagnosis and decide whether we need a paraclinical diagnostic procedure or not. Can anyone discuss this table?
Hi, Alti. I can discuss this table. So, like what Tia mentioned a while ago, our primary diagnosis is invasive breast cancer to consider invasive ductal carcinoma. And then the secondary diagnosis would be breast mass, probably benign, to consider giant fibroadenoma. So, this is the table for the certainty and the treatment modality. So, we put certainty of only 85% for invasive breast cancer because although the breast mass is already 13 by 6 cm. Initially, when the patient initially presented with a mass in OPD, there are already locally advanced disease presentations such as the skin findings, the ulceration, axillary adenopathy, and the prevalence is also it's the most common kind of breast cancer as well. So we put it quite high, but we're still not certain because the treatment modality is different between the invasive breast cancer and the breast mass probably benign. So we need more diagnostic tests in order to commit to this diagnosis. So next is breast mass, probably benign. We only put 10% mainly because of the prevalence. It's usually seen in patients who are pregnant, lactating, or adolescent women, and but somehow not that low, not 2% or 3% lang siya, because it can also present with ulcerations and bleeding, which was also reported by the patient as well. And the treatment modality would be surgical or conservative management. So next slide, please. So for the paraclinical diagnostic procedures, we would be choosing from 3 different tests. So first is the biopsy, the mammography, and the breast ultrasound. So actually for the patient, although we were told that we should presume that no diagnostics or workup was given pa, the patient underwent biopsy, mammography, and breast ultrasound all at the same time. So for this, for biopsy, the benefit is 95% because the sensitivity is 97% and the specificity is 92 to 99%. The risk is acceptable, and based on PhilHealth, it's 3,640 and it's available. So actually the patient has at least 4 out of 5 indications for the biopsy. So she has a breast mass, she has a family history of cancer, of breast cancer. Yeah, she has a hard, ill-defined breast mass in a woman of and any breast mass fixed to underlying chest wall or with skin changes. And the benefit is very high because it's the standard and the preferred way to diagnose breast cancer. And it tells whether one is invasive or non-invasive. So that doon pa lang masasagot na yung yung primary diagnosis natin. And it's also it also allows molecular testing for on biopsy samples to assess hormone receptor status and HER2 expression, just what Jade mentioned a while ago. So in terms of findings, we would expect, for example, if it's invasive ductal carcinoma, we would expect that there would be varying amounts of gland formation and cytologic features ranging from bland to highly malignant. But if it's a fibroadenoma, it's merely a cellular proliferation of stroma and glands. But of course, it would be it would differ then depending on the type of a fibroadenoma. So next is the mammography. We put it at 85% only because sensitivity is 77.3% and specificity is 98.7%. The risk is acceptable. The cost is only 1.2, and it's I'm not sure if I should put available because based on our tour in the radio department, the machines in PGH are non-operational. So maybe that's a non-available diagnostic procedure in PGH right now. So basically for this, for cancer, you would see microcalcifications or speculated high density mass, but for a fibroadenoma, it would just be a distinct area of breast tissue with smooth round edges. And finally, breast ultrasound. So it has the least benefit of all three, so 80%. It has a sensitivity of 76% and a specificity of 84%. It's acceptable and it's only 600 pesos when it's done in FMAB, and it's also available. But it's only done as an adjunct to mammography, and it should not be used alone. And for breast cancer findings, hypoechogenic speculated indistinct or angular margin, mass with the indistinct or angular margins can be expected in suspected breast cancer. And for fibroadenoma, it's usually seen as a well-circumscribed round to ovoid macrolobulated mass. So for this, given all of the data here, we would suggest that the patient undergo biopsy, mainly because it's the standard, um and the lesion is also already very suspicious looking, and we've already seen it, especially the photos prior to the chemotherapy. However, it's important that we discuss with the patient also, because they're the ones who would be paying for the diagnostic procedures. So is there an in the next slide, please? So for the paraclinical diagnostic procedure, it's the core needle biopsy. So we use a hollow needle to remove a suspicious sample from the breast and several small tissues of core of tissues from the breast, and it's performed under local anesthesia to numb the area. And markers can also be placed inside the breast to mark the location of the biopsy. So in future mammograms, you'll see where the biopsy was done. And it can be ultrasound guided. It can also be mammography guided. And the patient is positioned lying on stomach or on stomach or on a special table. So finally, I don't think we have the slide, but I'll just discuss some of the tests that were done to the patient. We don't, yun. Okay. Yun. So some of the tests that were done to the patient, we don't have the results talaga, but it was only reported by the patient. So first, the breast cancer receptor testing. So as Jade mentioned a while ago, and Alti mentioned a while ago, the patient is ER-PR positive and HER2 negative. So this is important for prognostic and therapeutic purposes. We'll also do the biopsy. I would also recommend that the patient undergo the mammogram as well, just to check the contralateral breast for any masses. The breast ultrasound would be low on the list of priority. And then next is the bone scan, the liver UTS, the 2D the checks X-ray are usually just imagings for advanced metastatic disease. So I think for this case, the reason why they did it was to screen the patient for any metastasis. And finally, 2D echo is a baseline for breast cancer therapeutics related cardiac dysfunction, as the patient will undergo chemotherapy and might probably have cardiotoxicity. So that's it for the paraclinical diagnostics.
Now we proceed to treatment. Again, we state our pre-treatment diagnosis and our goals.
So for this part, so our primary diagnosis again is invasive breast cancer, to consider invasive ductal carcinoma. And for our secondary diagnosis, we have breast mass, which is probably benign, to consider giant fibroadenoma. So first, we have to set our goals for treatment. So first is to do chemotherapy, which is important to reduce the tumor volume and allow for definitive surgery. And then later on to do surgery in order to completely resect the primary tumor and reduce the risk of local recurrences. And this is also important for the pathologic staging of the tumor and axillary lymph nodes to provide necessary prognostic information. So next, so according to the national breast cancer clinical practice guidelines in the Philippines, we can do chemotherapy uh, to maximize distant disease-free survival, and later on to do radiation therapy post-operatively to maximize the local regional control of and disease-free survival. So for the options, we have um, doxorubicin plus cyclophosphamide, and the clinical practice guidelines also um, show that in randomized clinical trials, they have seen a better disease-free survival among patients with axillary node positive breast cancer. But for the risk for this treatment modality, you can experience patients can experience nausea, vomiting, gastritis, peripheral neuropathy, myalgia, arthralgia, and other hematologic side effects. So for the cost, this is based from the drug price retail index. We can spend a total of 6,159. So by doing 2 vials per per treatment modality, and then we multiply this to 4 cycles, so we get this value. And then the clinical practice guidelines also show that after concurrent treatment with these two modalities, doxorubicin and cyclophosphamide, sequential treatment with paclitaxel showed a reduction in the hazard of recurrence and a reduction in the hazard of death for those dose-dense regimens. For the risks for this treatment, there are dose-related toxicities such as diarrhea, mucositis, myelosuppression, peripheral neuropathy. So that's for the risk. And then next for the cost, it's also expensive. So we can spend a total of 5,800. So that's 4 cycles. So 1,450 times 4 cycles. And then in terms of availability, both of these are available in public hospitals. Next. So the clinical practice guidelines also show that there's benefit in doing neoadjuvant therapy for patients with breast cancer. So for the options, we have tamoxifen with optional ovarian suppression or ablation. And for the benefit, it was shown that there's better disease-free survival among patients with axillary node positive breast cancer. And then, for the adjuvant endocrine therapy, the benefit for tamoxifen with optional ovarian suppression is that the use of exemestane plus ovarian suppression showed significantly prolonged disease-free survival versus using tamoxifen plus without ovarian suppression. But for the risk for this modality, we can experience, or the patients can experience hot flashes, nausea, leg cramps, and numbing or tingling sensation in the skin. So this is available in pharmacies. So this is tamoxifen costs 780 per 20 milligram tab. And then next would be, the other option would be to use an aromatase inhibitor with ovarian with optional ovarian suppression or ablation. So the use of aromatase inhibitor with or without ovarian suppression showed there's a significant prolonged DFS when compared to the other treatment option, which is tamoxifen with ovarian suppression. So for HER2 negative breast cancer patients, the treatment of choice would be the aromatase inhibitor with ovarian suppression. And then that's for the preoperative options. Next would be for post-operative options. So the patient can take paracetamol plus tramadol, which is the treatment of choice for the tramadol is the treatment of choice for pain management after axillary lymph node dissection in breast cancer patients. However, the risk would be dizziness followed by vomiting, nausea, somnolence, and constipation. And then this is also available in pharmacies. You can this is 18 pesos per 18 milligram capsule. And then the other option would be to use celecoxib. There's a study that shows that using celecoxib versus those who did not receive celecoxib reduce the hazard ratio for recurrence over 10 years by 35%. And then the risk for this would be a higher dose of celecoxib, 800 milligrams per day, might be related to augmented cardiovascular risk. So celecoxib is available in pharmacies. It's 18 pesos per 200 milligram capsule. And that's for the systemic options. So we can also do surgical options.
Okay. So to continue po the discussion, so we go to the surgical options. But before we go to the surgical options for the primary tumor, it is important to first evaluate the axillary lymph nodes of breast cancer patients. So for patients presenting with clinically suspicious axillary lymph nodes, we want to do ultrasound plus fine needle aspiration or a core biopsy para ma-determine if those lymph nodes are reactive lymph nodes or their nodal metastasis, because it also affects our surgical management. For patients with a positive biopsy, we want to proceed with axillary node dissection, wherein the level 1 and level 2 axillary lymph nodes are removed. But for patients with a negative biopsy, we want to do a sentinel lymph node biopsy, wherein yung first lymph nodes that drain the tumor lang yung tatanggalin at the time of the surgery. Okay, so we proceed to the options for the removal of the primary tumor. So first, we have the breast conserving therapy. So our major goal for breast conserving therapy is the preservation of a cosmetically acceptable breast. So yung benefits niya includes reduced operative time, diminished psychological burden when compared with mastectomy, and improved cosmetic outcomes, and also limited din yung kanyang side effects. But hindi lahat candidates for breast conserving therapy. So there are absolute contraindications, such as if multicentric yung disease or it involves separate quadrants na ng breast. If there is also presence of diffuse malignant appearing calcifications on imaging. Also, if there's prior history of chest radiation therapy, pregnancy, or persistently positive margins despite attempts at re-excision. There are also relative contraindications, such as yung large tumor size in relation to breast. So that's why we can also one of the candidates din po for neoadjuvant therapy ay those who desire breast conserving therapy pero hindi makaproceed dahil yun nga po yung size nung tumor ay malaki. So neoadjuvant therapy can reduce the size of the breast tumor. So next po is yung mastectomy.
Ayun, for mastectomy, sorry marami to, pero like, wait, let's go through some abbreviations first. So MRM is modified radical mastectomy. NAC is nipple areolar complex, or sometimes it can also mean yung neoadjuvant chemotherapy. Ayun. So with that in mind, So yung surgical options, as Miko has been talking about, there is breast conserving surgery, and generally that's the ideal kind of surgery, for our patients because it's superior cosmetic outcome and less psychological outcomes, tapos less complications with the surgery. But according to the ESSO, our patient currently is a case of locally advanced breast cancer, or what I'm gonna call Lab C. So for Lab C, as P has already established, mastectomy has always been the routine surgery, but in recent history, Lab C no longer precludes precludes breast conserving surgery. With the advent of neoadjuvant chemotherapy, as Mika was saying. Still, we should consider the following. Mastectomy is broadly categorized into either conservative or non-conservative, with further subgroups such as nipple areolar complex sparing, skin sparing, Patay's MRM, and Halsted's radical mastectomy, and simple mastectomy. The first two are considered conservative, while the last three are considered non-conservative. Our patient has no major contraindication to mastectomy in general, and major contraindications to mastectomy would include proven metastatic disease or poor performance status, or any contraindications to general anesthesia. Our patients ambulatory and mukhang kaya na mag-anesthesia, but we still need paraclinical diagnostics. The distinctions between conservative and non-conservative are mostly in the extent of surgical excision. However, we should consider that nipple areolar complex conserving mastectomy is already contraindicated in our patient, since the tumor is quite literally in the nipple based on the pictures kanina. And the contraindication includes less than 2 cm. Since our tumor is literally in the nipple areolar complex, NAC conserving mastectomy is already out of the table. It's good to note that the ESSO, oh wait, sorry, it's for reconstruction. All right. So common post-op complications of mastectomy would include bleeding and hematoma with risk factors of heart failure, pulmonary disease, obesity, diabetes. For non-conservative mastectomies, there's also a risk for seroma formation, and of course, the most dreaded complication of any breast cancer excision is the recurrence of regional tumors, and it's one of the primary considerations in breast breast cancer. According to the ESSO, for Lab C, stage 3B cancers would largely involve mastectomy. Since our patient also has involvement of many axillary lymph nodes, it's likely that we would consider Patay's MRM, depending on the biopsy findings of the lymph nodes. So it's sad, but BCS, or breast conserving surgery, can no longer be used in our patient, since the selection criteria for breast conserving surgery after primary systemic therapy is no longer met, i.e., residual tumor size of less than 5 cm and complete resolution of skin edema. In our history and based on the patient's own palpation, mas malaki pa rin yung tumor than 5 cm, and meron pa rin skin edema dun sa baba, no? So, but of course, we'd still need further paraclinical diagnostics to confirm this. Moving on to the next part. The next slide, po. Yeah. So breast reconstruction. Of course, after we excise the breast, we still have to reconstruct it. The goals of reconstructive surgery are generally wound closure and breast reconstruction for cosmetic purposes. According to the ESSO, cosmetic outcome is already largely regarded as being equal in importance to the risk of recurrence of recurrence of local tumors. Currently, there are two major considerations for breast reconstruction. One is immediate versus delayed, and two, which isn't in the slide, and I don't have a slide for this, but I'll just discuss it. And two would be free flap, autologous, or implant. What kind of plastic surgery are we going to do? For immediate versus delayed, IBR, or immediate breast reconstruction, generally requires longer hospital hours, longer recovery time, and higher risk of complications. There's a long-held belief that delayed recovery time leads to delayed adjuvant therapy, and that's always been a bad thing because that leads to tumor growth, and residual tumors might grow, etc., etc. But that's largely been disproven through clinical trials. The delay in adjuvant therapy is not clinically relevant according to clinical trials. However, if adjuvant radiotherapy is considered, Depending on the clinical diagnostics din yan, adjuvant radiotherapy is a contraindication to immediate breast reconstruction. Um, Inflammatory breast cancer, which we might also consider in a patient, also might be a absolute contraindication to immediate breast reconstruction. The main benefit of immediate breast reconstruction is that the patient does not have to come back for breast reconstruction at a later date. So overall, if you actually think about it, the hospital hours are shorter. Delayed breast reconstruction, on the other hand, requires a lot of foresight and a full clinical and staging assessment. But for delayed breast reconstruction to have good outcomes, patient factors need to be considered, like age, smoking, history, obesity. There's an entire list of it in the book of ESSO on breast cancers. When considering IBC, When considering IBC rin naman, patient selection is paramount. There's a clinical tool by Fisher, but we also need paraclinical diagnostics to use it. Ultimately, immediate versus delayed, we'd really just ask our patient what their preference is. But for our second consideration, we might want to recommend autologous flap. So the second consideration will involve mainly patient satisfaction. Patient satisfaction. So we have three options, right? Sorry. We have three options. We have free flap, we have autologous, and we also have implant-based reconstruction. Patient satisfaction was noted to be highest in implant reconstruction versus autologous and versus free flap. Functional problems related to abdominal donor site were reported only by a small minority of women in autologous flaps. However, since our patient is currently 45, and the fact that autologous flaps are more stable in the long run than implant-based reconstructions, we'd likely recommend that our patient would avail of autologous IBR or DBR. Significant post-op complications are also related to significant post-op complications are related to implant-based reconstructions, lalo na the ESSO sites, displacement of the implant, infection of the implant, and rupture of the implant. So to avoid these, autologous flaps are recommended. Free flap naman po, a reoperation rate was also high at 11%. So parang based on our patient profile, we might really want to recommend an autologous implant decision. Generally, mastectomy patients are hospitalized for 2 to 5 days. With immediate breast reconstruction, the inpatient stay will extend to 4 to 7 days. And then for delayed breast reconstruction, the patient will have to go 2 to 5 days of the breast excision, of recovery for breast excision, and then 4 to 7 days again at a later date, mga 6 months later or 3 to 6 months later. 4 to 7 days of hospital stay. So overall, IBR will still have less hospital hours. Yun po. So next, moving forward, we can move na.
Now we'll discuss prevention and health promotion. So you have to give advice on health maintenance and disease prevention.
The most important thing to consider with educating the patient and the patient's family is to discuss with them the possible risks of acquiring breast cancer, given that they have a first degree or a second degree relative with breast cancer. So based on reading, there are a lot of organizations that have differing opinions on when to start checking the breast for cancer, and also when to start mammography. And on the left, we see that we see the different risk factors and their associated risk ratio in developing breast cancer. So we see that one of the highest risk factors is having relatives with breast cancer. And then one of the lowest is having children at a later age. I think it's based on this based on the diagrams on the left and the right, it's important to discuss with your patient and to find out what are their risk factors for developing breast cancer. And depending on the age, well, in this case, at the age of starting 40, when they start coming for consult, it's important to discuss with them what they prefer. If they would like what they would prefer, would they like to be examined every year, and what kind of exams would they want to do. But it's also important to discuss with them the risks and the risks and possible benefits of each test that they want to do. The most common test the most common test for breast cancer, most common imaging is mammography. So if they prefer mammography at the age of between 40 to 49, then you have to talk to them.
Is low. Please recharge in time.
It's important to talk to them about the different possible risks
Battery is low.
of the
Please
patient.
recharge in time.
Uh, next slide, please.
Battery is low. Please recharge in time.
And then also it's important to talk to the younger members of the family, most especially the ones at 18 years old to 25, about ways to prevent breast cancer. So the most important is to not initiate smoking and maintaining weight, as well as um doing self breast exams if whenever they can. So yeah, that's all.
We're done na po with our presentation, sir.
Hello, hello.
Hello po.
Okay. Something went wrong with my microphones. Doesn't work. Can you hear me?
Yes.
Okay. Hello? Okay. Okay. You can all hear me now?
Yes po, sir.
Okay. So, can you turn off first the PowerPoint? Okay. Well, okay. First of all, I'd like to congratulate you for a quick preparation for the discussion this morning. Okay. I know probably some of you did not sleep. Okay. And then thank you also for following the framework. As I told Kenneth, just try your best because it's one of last moment's notice. Okay. But I think you did your best. Okay. So offhand, I'd like to ask you your feedback. How do you like it? How do you like the framework? Before I discuss the details later on. No? How do you like it?
Sir, may I?
Sure.
I answer. Kasi the framework's super useful for clinical experience. And it would have been nice to have had that framework at the start of this year when we started our clinical rotations po. Kasi lost po talaga kami sa clinics. But if we had that framework, we'd have an idea of what's going on. We were always lost. What step were we in the process? But I guess it's never too late to learn it now, sir. It's really nice, sir. The framework's good. The framework's really applicable po.
Okay, thank you. But I like to confess to you that my framework is not, I've been teaching this since 1985, no? To not only when I give lectures to medical students in UP College of Medicine, but in other schools that I help, no? Like Ateneo de Zamboanga and Bicol Christians. I've been teaching this framework and also among the surgical residents, no? But of course, not everybody would like to take it up. Okay, so I cannot really force it also in the college. No, okay. So I'm just trying my best to extend this to you during preceptorship. No, okay. So that's the best that I can do. Okay. So any other comment? Thank you for the comments, Leonardo. Any other comments?
Ako po, sir. So, given po nga na it's actually our last rotation, and then medyo ang dami na namin napagdaanan na OPD. If you take a look at your algorithm, medyo similar po siya sa mga ginagawa namin already. Though, mas, mas purposeful or mas may intent yung bawat step. And so you better appreciate the process talaga if you take a look at your algorithm na step by step. Meron ka talagang objective, meron ka talaga yung gustong result, tapos meron ding sense on how or why you move into the next step. So, parang it made a lot more sense yung entire way of how to discuss things or how to approach an interview or management of a patient. So, na-appreciate ko rin po talaga.
Okay, thank you, Pia. Is this your last day?
Our last rotation po. Meron pa naman ata kaming OPD next week. Tama.
Next week. I thought this was your last day. Yeah, that's why I forced myself to squeeze my schedule in. No? Okay. Anyway, yeah, I agree. Everybody has been doing it. All clinicians are doing it. Just a matter of putting it more structured. No? Okay. So just like in the when you come out with clinical diagnosis, so even clinicians, I think they just have one or two possible differentials, rather than a whole gamut of 10, 20 differentials that you hear in the discussions in the classrooms, diba? In the conferences, Okay. So usually they have one or two, sometimes even one only, So which is not also good. They should have at least another differentials, Okay. So they stick to one diagnosis and then they go for the treatment, order a lot of tests. Or some would have two or three or four, and then they come out with shotgun diagnostic tests, just to get to a particular diagnosis, Okay. So as to the degree of certainty, I guess all clinicians have that also in mind. Even you've been exposed to the clinics when you see a patient, parang you said, ay, tama ba ako? Ito nga ba yun? Ganon, di ba? Okay. So there's a feeling that you want to know how certain are you with the diagnosis that you can proceed further, di ba? Okay. Ginagawa lahat yan, di ba? Okay. So what I did just to quantify it, okay. Quantify it. Okay, let me, at this point, okay, baka makalimutan ko mamaya, kasi this is a very common question. How do you quantify the degree of certainty? Di ba? Okay. Okay. But I know that that's being done by everybody. Okay, but how to quantify it? Yan ang challenge, no? So I've been looking at the literature to help me come out with a description with the methods of quantifying. Mahirap, I have difficulty looking for one. So before I used to use, baka pwede na yung mga so-called pattern it after the research na 95% confidence interval, 90% confidence interval, ganon, di ba? Pero wala, ano? And then there's no literature that will say that if you have such a diagnosis, it should be classified as more certain, not certain, ganon. No, wala, no? Okay. So I just ended up with my own suggestions, no? Okay. So you just classify it into two, certain, you're certain or not certain, just two category, no? Okay. So ang basis for saying you're certain is if it's more than 90%, 90 or more, okay? And then not certain, less than 90. Ganun na lang, na? Okay? Okay. Now, why do I use 90? Yeah, I mean, yung minimum confidence interval is 90. And practically all diagnostic tests, 90 rin ginagamit na as acceptable. Kung less than 90, it's not an acceptable diagnostic test. Diba? Okay? But you can go beyond 90, no, to categorize it as quite certain, but never reach 100%. There's no such thing as 100%. So the highest will be 99%. Okay? 90 to 99% certain, less than 90% not certain. So not certain can also go down to 60%. Wag yung 50-50, which is a common expression of doctors to patients. 50-50 yung chance ito, ganun nga, 50-50. Na? Okay. So we doctors must come out with an educated guess. And we also know that medicine is an art of probability. Okay? Art of probability lang yan, di ba? Okay. So 60 to less than 90, not certain. No? And then more than 90 to 99% quite certain. No? So there are various data and information that you get that you can use to quantitate your degree of certainty. No? Okay. So example, number one category is if you, for the diagnosis, if you base your diagnosis on a pattern recognition, no, rather than prevalence, okay? Prevalence just means how common is it in the community, okay? If you use that, not quite certain, tama, okay? But if you invoke pattern recognition, what is the usual appearance of a particular clinical condition, just like in this particular case, meron siyang pattern of a breast cancer, so you can say that you're quite certain, no? Okay? And then you reinforce it with prevalence. It's common in the Philippines, di ba? So example here, probably in my case, if I am a experienced clinician, when I see this patient, probably I'll put it at 95 at least, okay? 95 because, or even 98%, no? Okay? No? But for you, okay lang, no? That's why in this algorithm, I allow some areas of learning, no? Okay? So kayo, kung let's say bago lang kayo, you can put it at 85%, no? Then after the experience, when the outcome came out to be that this is really breast cancer, you can see that you learn from this particular case. Next time you see another patient like this, you will now increase your degree of certainty. No? Okay. Okay. Now, if it's based on just prevalence, as I said, you're not certain. No? Okay. If it's based on pattern recognition and then reinforced by the prevalence, you're quite certain. No? Okay. Okay, so the other guide that you can use if you base your clinical diagnosis on signs and symptoms, right? Symptoms come from the history, signs come from the PE. Okay? So which do you think is more reliable? Symptoms or signs?
Science po.
Signs, di ba?
Science po.
Okay. So if you base your diagnosis based on signs rather than symptoms, no, you're more certain with your diagnosis, okay, rather than just the signs. Just like in this particular case, yung history niya, 4 years, no history, I don't think that's reliable, di ba? Ang laki-laki na eh, no? So probably that 4 years was a time that the mass was noted, no? So it started probably even probably 7 years or 8 years ago, no? Okay. So if you just rely on the history of 4 years, medyo unreliable siya, di ba? Okay. So ganon. So prevalence and pattern recognition and prevalence will contribute to the quantification of degree of certainty, and then signs and over the symptoms, okay? And of course, your experience, no? So over the years, your experience will count, no? So if you have a lot of experience, you can input that, no? As part to quantify your degree of certainty. Yan ang ginagawa ng clinician, yung mga matatanda na maraming experience. Sigurado ako dyan, no? But they don't quantify it, no? For the learning of the students, di ba? Okay. Are those statements true? Na-validate niyo? Nakikita niyo yung from the consultants? Okay. Now, as to the general comments muna tayo on the framework, no? So after the degree of certainty, no, you can see now that will be the stepping stone or the start of answering the question, do I need a paraclinical diagnostic procedure? Okay. So the assumption here is, although it's a common practice, is that the perception is that all patients should need a diagnostic test. Tama? Okay. But there are instances in which you don't need a diagnostic test. So it's common sense, di ba? So if you're quite certain, let's say 99% certain ka na or 98% certain ka na, rationally, you don't need a diagnostic test anymore. You can proceed to the treatment. Tama? Okay. So the indications for paraclinical diagnostic tests will be the degree of certainty. If you're not certain, less than 90, you go for a diagnostic test. So i-justify mo lang, na? Okay. Now there's an exception there. You are not quite certain of your primary and secondary, but the treatment will be the same. So you don't need a diagnostic test. Okay. So an example is that if you have a mass on the subcutaneous area, okay, so it could be an epidermal cyst or lipoma, no? So you don't know which is which, but anyway, the treatment there is an operation. If the treatment is an operation excision, you don't need a biopsy before the operation, no? You just remove it, you know? So that's an application of the uncertainty in the diagnosis in which you don't need a paraclinical diagnostic test. No? Okay. Now, another exception is that in this particular patient, if your diagnosis is, as I said, from 98%, 99%, no? Okay, breast cancer and itsura-non, no? So you can justify your diagnostic test by saying the treatment is very radical, no, very extensive, from the planned treatment. Okay, as you mentioned in your table, the patient will need systemic chemotherapy, radiation, and operation. No, okay, so very extensive. So you can justify it. You want to be more certain. You can probably want to reach it to 99%. No, okay, 99% degree of certainty. Okay. Kasi based on evidence-based medicine, kung 98% ka na, you don't need diagnostic test ka na. You don't need diagnostic test anymore because you're just going to increase it by 1%, di ba? Di ba? Yan ang turo ni Dr. Dance, tama? You passed through Dr. Dance already? Evidence-based medicine. Okay. So yun, na? Okay. Now, yung BRCA, okay. So I'd just like to comment, okay. So after you've decided on the clinical diagnostic test, you now decide, you put down the options, and then compare the different options in terms of benefit, risk, cost, availability, okay. So at the moment, most of the clinicians just base it on the benefit and the risk, okay, more on the benefit, okay. But they don't input the cost, okay. Do you agree that cost is very important? Kasi kung minsan di kaya ng pasyente yung pinakamahal na okay. So, okay. And then, the availability is also important, di ba? Example, somebody mentioned PGH mammography is non-functional, di ba? Okay. So you have to consider that, availability. If it's non-functional, you cannot do it. So you can go to the next option, or you refer this patient to another center, di ba? Okay. So this is very important when you become doctors to the barrios, di ba? 2 years from now, 3 years from now, some of you might become doctors to the barrio. Walang available na diagnostic test doon, di ba? So you have to, you can factor in all this data, okay? And then, okay, before I forget, yung cost na yon, okay. Okay lang because I don't really expect you to produce all the numbers in terms of the pesos, But the approach here will be, don't look at the PhilHealth muna, Mababa ang PhilHealth. Look at the running rate of the for the diagnostic test. You look at the running rate of the hospitals, the institutions, okay, offering those tests. Iba-iba, di ba? Okay. Example, mammography will be at 3,000, 4,000 sa big centers. Okay. In PGH, probably, as you mentioned, probably 1,002, 1,000 something, di ba? Okay, iba-iba, But there's a cost involved, So you look at the running rate. That's why, at times, in my personal practice, I don't ask them to go to a big set hospitals for the diagnostic test. If they need mammography or ultrasound, I ask them to go to a clinic or institutions that will offer lesser cost. Okay? Ganun yun, And then, for the treatment naman, ganun din, is a surgery, Okay? Chemotherapy. Chemotherapy usually standardized na yun, but you look at the PF of the oncologists, the medical oncologists, they have different rates also, For the surgeon, different rates din yun, So you look at the right, kasi you might have some relatives who will be undergoing surgery or chemotherapy, So yeah, you know how to advise them. Sabi mo, you go to the surgeon, mura lang magsingil yan, ganon, Or you go to PGH kung hindi nyo kaya, mag-charity kayo. Or you go to PGH private, at least mas mura ang singil, Okay, ganon, So that's importance of inputting the cost, Okay. 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 So I hope with this framework, it will also facilitate your explaining to the patient, how to go about it, So sa ngayon, tama yung ginawa ninyo, you have a lot of extensive explanations, including the pathophysiology, epidemiology, ganon. Okay lang yan. This is part of the learning and also part of your preparation for your board exam, Because anything goes to board exam, they ask a lot of questions, Okay. But when you talk to the patient, you simplify it, You simplify na lang ninyo, Okay. So you use that framework to talk to the patient also, To discuss it with the patient. An example is that once when in the BRCA, you present those data to the patient in a simple way. Wag yung ngayon, I will amplify on that later on. Very extensive yung explanation niyo, Okay, you can simplify it And then you ask the patient, after presenting the data, what do you want? Na? Anong gusto mo? Na? Okay. But most of the time, patients will always return the question to you. Doc, anong sa palagay mo ang pinakamaganda? Di ba? Yan ang tinatanong. No? So what do you do? No? But at least you gave the information to them already. That's an informed consent already. Di ba? First part of informed consent. No? Then after that, you try to be objective about the comparison of the data. No? Okay. Ngayon, you have to input also other factors. No? Kung yung pasyente ay may mindset na kailangan gawin ko ito because of past experience, no, you may have to give in. Kahit na it's not the best, no? It could be the second best. No? Okay? And then also you have to factor in the psychological makeup of the patient and the relatives. No? Okay? So yeah, adjust lang ninyo. No? Okay? So you can go for the second best. Okay? Kung yung pasyente talagang gusto niya pinaka-sophisticated treatment, so you give the most expensive one. Kung gusto niya talaga yun, no? Kung kaya niya. No? Okay? Okay? So that's an example of how you can advise your patient using the BRCA. Bigay mo lang yung data and then explain it to them, then you get the informed consent. So from experience, actual experience, and only a few doctors are using the informed consent. No? Usually, kung meron man, verbal lang, di ba? Verbal. No? Kung isa nakakalimutan ng mga pasyente ko anong sinasabi ng doktor. No? Okay. Ang pinakamaganda dyan, isulat ninyo and then give a copy to the patient and then let them decide. No? And then once they chose a particular option, let them sign, put a signature to what they chose. No? So that's an informed consent already. No? Okay, yan ang kulang sa ating mga in the practice of medicine ngayon eh. No? Okay? Okay. Okay. Before we go to the details of the case, no, any question, any feedback again on the framework? Wala na? Okay. So this 45-year-old female presenting with a breast mass. No? Okay. Okay, first, I'll just interject some mga practical inputs. No? Okay. When I see a patient for the first time, what's your concern? Nasabihin niya may bukol. No? I have a breast mass. Okay. So in my records, okay, I'll put a breast mass concern. Okay. I don't usually use chip complaint anymore. I just put chip concern of the patient. So breast mass, then I put a open, close, quotation marks. Quotation marks, di ba? On the mass. Okay. Okay. So I have to check first if the patient really mean a mass. Di ba? Okay. So minsan kasi, sabihin nila may bukol, pero hindi pala, when I after examine the patient, hindi pala bukol talaga yun. No? Probably it was a prominent xiphoid process, no? Prominent rib, no? Or a fibrocystic change na prominent lang. It's not really a mass, no? Okay. So I usually put the quotation marks on the word mass. Okay. Then I put the side also, the left side, no? Okay. So then as to the history of the present illness, you just say it was noted 4 years ago. Okay. The assumption that it could be there earlier than 4 years ago. Most likely it was there kasi meron ng skin changes, di ba? May mga ano. Okay. And then, so, up to now, I'm still trying to see iba-iba yung rate of growth kasi kung rate of growth of a breast cancer, no? Some, usually 2 years lang, ang bilis-bilis, no? But most of the time, mga 3 years or 4 years, no? Bago lumaki, no? Okay. So it's hard to really predict, but so the advice really is for the patients to seek consult as soon as possible, because we can never predict the rate. We can never tell the rate of the growth of the mass, di ba? Okay. Yung sa kanya, 4 years, ang laki-laki na eh, di ba? Okay. So it might have been there more than 4 years ago, no? And then yung pandemic, they use the pandemic as a reason for the delay in consult, no? Pero even without the pandemic, dinidelay din nila, di ba? Okay. So anong usual reasons for the delay? Number 1, ignorance, di ba? Ignorance that they really have breast mass, no? Okay, hindi nila kinakapa kasi. Ay, number 2, yung binabaliwala nila, hindi kasi masakit, di ba? Benign lang ito, baliwala ito, no? Okay. So, others naman, konting sakit lang, magpapatingin na. Okay yun, di ba? Okay, kahit na wala ka, baka fibrocystic lang yun, di ba? Okay. Now, the other reason for that, minsan, walang pera, di ba? Titiisin na lang nila, no? Okay, walang pera, no? Okay. So yung delay can be seen even before the pandemic and even up to now, after the pandemic. Okay. So we really, it's best, okay. Nice to educate the public. Kaya lang, we have not been very successful in that. No? Okay? Ang hirap, no? Okay. But just the same, try our best to educate the public. No? Okay. So use social media, whatever, no? Try your best na lang, no? Okay. You can interrupt me anytime. I'm just looking at my notes. Okay, the use of pattern recognition. Okay, let's jump to the you came out with the primary diagnosis of breast cancer, no? Okay. Secondary diagnosis is giant fibroadenoma. Okay. So as I said, the first process that you use is the pattern recognition, and then prevalence. Okay. So what is the yung breast cancer, no? Okay, it jives with the pattern, no? Okay, a mass, then skin changes, erosions, no? Okay. How about fibroadenoma? Is there a pattern for fibroadenoma there? Medyo wala eh, diba? Usually fibroadenoma, usually walang skin changes, diba? Okay. I won't blame you for that. Okay lang, mahirap talaga. I'm forcing you to have a primary and secondary kasi, diba? Okay. So primary is usually malignant, benign, or the other way around. Kung benign ang presentation, malignant yung secondary mo, diba? Okay. But you must have some basis for saying that this is baka fibroadenoma. Okay? Okay. So kung di malapit to sa fibroadenoma, you think of other things. Na? Okay. So an example, kasi may mga skin changes na ito ay pumutok na eh, di ba? Okay. So you can think of TB. TB is another benign one. Na? TB of the breast. Na? Okay. It's not very common, but it occurs in the Philippines. No? Okay. TB of the breast. It can have some erosions, rupture. No? Okay. Okay. So ang ilalagay niyo TB. No? Okay. Kung may different types of cancers naman, sa ngayon kasi the most common is invasive ductal carcinoma. And the second is the sarcoma. Okay, yung sarcoma pwede rin, pero it's not the typical malaking-malaki yung breast mass ng sarcoma, di ba? Okay. So, kung different types of breast cancer, you can use that, no? Primary and secondary, depending on the type of the cancer, no? Okay, but most of the time in breast, usually 98% invasive ductal carcinoma yan eh, di ba? Okay. So, ang next is benign na yung alternative diagnosis mo, di ba? So, here you can think of TB of the breast, na? Okay. And then, ang suggestion ko, when you look for the pattern recognition, as I said, focus tayo, di ba? Focus, history, and PE exam, no? Okay. My suggestion ko is put it, I won't say remove, just put it on hold, put it in the background. Yung mga risk factors, no? So risk factors, essentially, it's not part of prevalence, no? Kasi prevalence is whether it's common or not common in the community. So the one who discussed on the risk factors like the age, gender, nulliparity, alcohol drinking, no? Family history, no? Personal and social, ganon, no? Okay. So rarely does it contribute to the diagnosis, no? Except probably the age. Age is common. You use the prevalence, it's common in this age group, di ba? Okay. But the risk factors, mahirap i-pinpoint ngayon, no? Maraming probably 25 years old and below, okay, baka most likely benign. But even if 25 and below, you still use the pattern, no? If there's a pattern of breast cancer, kahit na 25 years and below siya, your primary diagnosis is still breast cancer, okay? So you don't let the age, don't let the family history, ganun din, no? Change your diagnosis when you base it on the pattern recognition, no? Okay. Example, if this particular patient has the same signs and symptoms, no? Pero without family history of breast cancer, you will still stick to a breast cancer diagnosis. Tama? Okay. Okay. And a 30 years old presenting with a benign looking breast mass with a family history of breast cancer, you still stick to a benign lesion rather than being swayed by the family history as the primary diagnosis. Okay. So you give more priority on the characteristics of the mass that you see on PE. Okay. Questions? Questions? May konting parang
Pero sir, we can, yun kasi,
yeah.
we can still mention it, pero hindi po siya hindi po malaki yung weight niya, bale. Ganun po ba tama?
Yeah,
Yung
you
risk
can mention it in the
factors.
discussions. Pero when you go to practice, no, hindi mo rin sinasama yon. Okay. Tama? When you go to clinical practice, you come out with clinical problem-solving decision-making already. No? Okay. So parang yung nulliparity, halos wala. We don't invoke that anymore. No? Okay. Parang for efficiency purposes, you just rely on the pattern and prevalence. You can get to a 99% accuracy already, as high as 99% accuracy of the clinical diagnosis. You don't have to go through the wasting your time. You have a nullipar, even the gender, female, alam natin, babae, di ba? Okay, yung alcohol drinking, no smoking, okay? So, just go direct to the point, no? Okay. So, yung mga clinicians, they don't ask that anymore, no? No, alcohol drinking ka ba? So right away in the chart, breast cancer na ito. Okay. Okay. So the algorithm, okay, a word about pain. Pain is not a very reliable diagnostic sign or symptoms, no? Unless you're thinking of a abscess, no? Okay. Or pag walang mass, basta importante din, ganun lang yan. May mass, may problem. Now there's a problem. If there's no mass, basically there's no problem. Okay, that's the guidelines that I usually use. If there is pain, there is no mass, usually no problem also. Okay, those are the three formulas. Okay, mass, may problema. No mass, usually no problem. Yung palpable mass, palpable mass. And then with pain, with no mass, usually no problem. You tell the patient what you have is fibrocystic changes. Fibrocystic changes, hormonal changes. Okay? Okay. So when you palpate the patients presenting with the concern for a breast mass, so-called breast mass or breast pain, kapainan nyo kagad. Then if you see no mass, no, wala kang nakakapa, you're confident no mass, no, walang problema. But there's a mass, you have to investigate already. No? Okay, go further. But if there's no mass and then there's no pain, sabihin mo sa kanila, no problem. stick out your neck, sabi mo, no problem. But, okay, do not use the word normal. Na? Okay, pag mong gamitin the word normal, na, that's my suggestion. Na, called from clinical experience, na? Because before the advent of ultrasound, I usually tell them it's normal. With the advent of the ultrasound, maraming nakikita sa ultrasound, di ba? Nodules, 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 pero no palpable nodule, masses on the breast. Yeah, babalik sa akin ang pasyente. Bakit po sa ultrasound may mga bukol-bukol? Sinabi niyo wala, normal. Na? Okay? So now I usually tell them, you have fibrocystic changes. So that will facilitate my explanation for the findings on the ultrasound. Kasi sa ultrasound, maraming makikita na? Okay? May mga cystic areas, may mga so-called solid nodules pero not palpable. Those are fibrous changes. Na? Okay? But emphasize to them that this is still normal. Idadagdag lang ninyo. Kasi kung minsan hindi alam mga pasyente, ay, may sakit pala ako, fibrocystic changes yung sakit ko. Na? Okay. So you have to emphasize to them that this is still normal or give an explanation kasi pag nagpa-ultrasound ka, baka maraming makita, mahirapan ako mag-explain sa iyo, di ba? Okay. Okay. So the other algorithm that I would recommend that you use in terms of evaluation of mass, breast mass, or any mass for that matter, mga surface mass. Okay. So the first step is to look for signs of inflammation. Okay, because the reason for this, ito yung step by step, yung signs for inflammation muna, then signs of malignancy, and then benignity. Tatlo lang yan by elimination, di ba? Because yung signs of inflammation, madali ma-recognize, di ba? Okay, so you look for signs of inflammation first. So if you have a breast mass which is tender, which is fluctuant, which has erythema, redness, right away, diagnosis mo is abscess, di ba? Okay? Kung negative signs of inflammation, infection, you have to choose now between malignancy and non-malignancy, benign, okay? So the next step is to look for malignancy rather than looking for signs of benignity, na? Unahin mo na yung malignancy. Mas madaling hanapin yung mga malignant signs, na? So skin retraction, nipple retraction, okay? Okay. Axillary nodes, just one of them present will make you suspect malignancy already, di ba? Okay. Ngayon, yung mga earlier stage of breast cancer, yan ang mas mahirap, no? So mga earlier sign of breast cancer, signs of malignancy could be ill-defined border. No? Basta solid with ill-defined border. Now, when you palpate it, hindi mo ma-delineate yung border ng gusto. We call it ill-defined. No? Okay. So that's the first. If you have such a finding, you suspect malignancy already. No? Okay. At that point, baka 60% lang yung suspect mo. 60% degree of certainty. No? Okay. Now, pag may kasamang fixation to the overlying skin, saka underlying skin, you suspect malignancy, now probably the degree of certainty will go as high as 80%. Okay? Nakikita niyo yung graduation? No? Now, if you are able to palpate the lymph node on the same side, your degree of certainty will now go as high as 90% or even higher. Okay? Nakikita niyo yung degree of certainty? Okay? Kung meron ka mga skin changes, pumutok na, baka 98-99% na yan. Na? Okay? Kasi yung TB is just 1% lang yan eh. Na? Kung TB siya, 1% lang. So, okay? So look for signs of malignancy first. Kung wala, negative, you settle for benign. Most likely benign siya. Na? There's only one sign for benignity that I know of. No? On PE, ha? Cystic. So, ipipress mo lang yung mass, titingnan mo kung madidepress yung skin over the mass. So that will signify that most likely the mass is cystic. Pag cystic siya, sabi mo, ay, mukhang benign ito. Okay? So kung benign ito, you're quite sure, sabi mo sa pasyente, most likely this is benign because it's cystic, no? Now, if you want, we can do the aspiration now, no? Okay, kung ma-aspirate natin, we get fluid, lumabas ay fluid na wala yung bukol, okay? So the patient will be very, very thankful to you kasi she came in with an anxiety, baka breast cancer, di ba? So pag tinanggal mo yung bukol, nawala, magic, di ba? So malaking pagsasalamat ng pasyente sa iyo yan, no? Okay? So right first consultation without ultrasound, without mammo, aspirate mo lang, nawala na, tapos na, no? Okay? Questions? Questions? Wala. Okay. I still have 30 minutes to go. Paraclinical diagnostic procedure. Okay, let's go to the paraclinical. So Kenneth was asking me kung anong starting point nito to assume na first time or ano. Okay. So where do we start with the discussion on paraclinical? Yung pasyente ngayon, operahan pa lang, di ba? Nakita niyo kahapon?
Yes, sir. Today yung surgery niya.
So you saw the picture of the breast mass. You saw it. Yung present niyo kanina, is that the picture?
Yes po.
Yes po, kami po nag-take ng photo na yun.
Ah,
We're the ones who took the photo po.
okay. Sige. Sige. We start from that point. Okay. So sabi natin nakita niyo on PE. Okay. What diagnostic you want to be, your primary diagnosis mo is breast cancer, number 2 is TB. Okay? Dito tayo magsimula. Okay? So do you need a paraclinical diagnostic procedure? We said yes, di ba? Because we want to be more certain. We want to be as high as 99%. Kasi TB pwedeng gamot, di ba? Pwedeng anti-TB, di ba? Okay. So what paraclinical diagnostic procedure would you use? So you list down biopsy, mammo, ultrasound. Of course, there are others, no? Okay. There are others that you have heard of, like CT scan, MRI, no? Okay. So eventually, baka ma-replace ng mammo yung ultrasound ng CT scan, MRI. MRI is so popular now. Baka kung minsan, PET scan pa nga, di ba? So a lot of times it's a matter of who's pushing the industry, no? Who's trying to sell the diagnostic procedures, no? Okay. So but at the moment, at present, let's just talk about biopsy, mammo, and ultrasound, no? Okay. So before we go to the comparison of the three, just a word comment on. So when do you use ultrasound or mammo guided biopsy? Sino kayo naglagay noon? Mammo ultrasound guided biopsy kayo? O ginawa sa pasyente yon?
Ay, sir, ginawa po sa pasyente, sir, but when we made the PowerPoint po kasi parang we thought na yung initial presentation pa. Yung ngayon po kasi na presentation ng patient, nag-decrease na po yung mass because of the chemotherapy. Iba po yung presentation niya initially.
Okay. So na-biopsy siya after
Opo.
the chemo.
No, sir. Nag-biopsy na siya, nag-mammogram, and nag-ultrasound na po siya, sir. But we
So,
just
yung
worked
initial
with the
biopsy
assumption
niya-
na wala pa po lahat ng workups na
Yung
yun.
initial biopsy niya, anong biopsy ginawa sa kanya? Ultrasound guided pa rin?
We don't
don't
have
know.
any idea, sir.
Hindi niyo alam.
Mm.
Wala kayong data.
Wala po, sir.
Okay, you don't have the result also.
No, sir.
Okay. Sige. So you don't have a result of those diagnostic procedures right now. Okay. So anyway, a word about that kasi very rampant kasi yung practice ng yung mga not really indicated, no? A lot of times I would say that hindi siya no strong basis, no? So very rampant na yung tinatawag na ultrasound guided, mammo guided, no? Especially ultrasound. Ultrasound is kasi very madaling gawin yon, no? So for palpable mass, usually pwedeng hindi na ultrasound guided, no? Diretso na, no? Okay, kasi that will be added, yung ultrasound, using the ultrasound will be added cost, no? Kung mga maliliit lang, no, let's say there's a doubt that you might not hit the mass accurately, then you go for ultrasound. Pero dapat honesty system na yon, no? Okay? Kasi ngayon, to tell you, a lot of physicians are practicing the so-called ultrasound guided biopsy, no? Okay? Lalo na ngayon with the ultrasound report of maraming nodules, BI-RADS 4, yung mga alam niyo yung BI-RADS 4, BI-RADS 3. You're aware of the BI-RADS? Anthony, are you aware of the BI-RADS, Anthony? Anthony Joseph? Kabisado mo yung BI-RADS?
Hindi naman sir. Familiar lang. Yung ito yung sa
Sige, ano yun?
yung sa imaging for the
Yeah.
breast cancer ma'am.
Yeah.
So,
BI-RADS stands for breast imaging.
reporting and data system.
Yeah. So they have how many categories? 0, 1,
Up to 6. So
up to
7.
6. Very good. Okay. So kadalasan meron pag BI-RADS 4, recommended na biopsy, di ba? Okay. Pag 0, needs additional test. Okay. Remember that one, BI-RADS 0, I will discuss it later on. Pero sa ngayon, BI-RADS 4, usually they need a biopsy. No? Okay. So kung BI-RADS 4 at palpable na yung mass, you don't actually need to have an ultrasound guided. No? Okay. For the non-palpable mass, you need an ultrasound guided or even a mammography. Kung nakita sa mammography yung bukol, no? Okay, you have to be very selective, no? I-justify mo lang, no? Okay. Now, yung so let's start with the mammo muna. Ay, biopsy na lang. Biopsy, there are three or four types of biopsy, no? So you have the needle aspiration biopsy. You're aware of that? You're not aware because it's not commonly practiced in the PGH anymore. Wala. Core needle ang naririnig ninyo. Tama? Core needle. But we started with fine needle aspiration biopsy, which still being done for thyroid, no? But for the breast, no? Halos wala na, no? Okay. And then core needle. And then the other one is tinatawag na open biopsy. It could be a section or an excision. If the mass is small, you just remove the whole mass, okay, for biopsy. Section, if the mass is big, you just remove one part, let's say 1 centimeter chunk of tissue, and then submit that for histopath, okay? So the fourth type is the so-called frozen section. It's a rapid test, no? It's an open but frozen, no? Okay, rapid test, no? Okay. So indications for this 4. Okay. So kung pwedeng needle biopsy has fine needle biopsy has an accuracy of 90% or more. Okay. And then core needle biopsy has a yield of, sabihin natin, 95 to 97, example, no? Okay, of course, literature will have different ranges depending kung kaninong experience, no? Then open biopsy will have 98 to 99, walang 100%, ha? No such thing as 100%. Ganon din sa frozen section, no? Okay? So if you were to choose between among these 3, no? Among these 4 pala, these 4 So I have given you the benefit, the comparative benefit, no? Okay, we're talking about diagnostic test, so we're talking about the yield, no? The accuracy, no? So 90%, 90 ganon, no? Okay, that's how you compare the diagnostic test, no? And then the risk, ano yung risk ng fine needle? Tusok lang? Pain lang? May konting infection? Small chance? Okay, hematoma? Small chance? Okay, so that's where you put your risk. You have to tell the patient, no? Okay, may konting sakit lang sa tusok, no? Kumisan, bihira-bihira naman, may konting hematoma, no? Okay. And then kumisan, infection, no? Okay. And then for the core needle, again, you tell them, mas malaking karayom, okay? May anesthesia, yan, di masyadong masakit. Yung sa fine needle, you don't need anesthesia for that, no? Okay. So sa core needle, you put an anesthesia, mas mataas ang chance ng, hematoma, no? Okay. Okay. And then infections is also another possibility. Then for the open, the risk will be you have an incision there, may hiwa ka, no? Again, you can have hematoma, you can have infection, no? Okay. So an advantage ng frozen is rapid, malalaman mo kagad, no? Pero then you explain the cost, no? Cost, no? So pinakamahal dyan yung frozen section, di ba? Kasi admitted yung pasyente, no? Okay. So the cost for frozen section in the private hospital will cost you about 20 or 30,000 more, including the lab and also the pathologist, no? Okay. Now for the open biopsy, local anesthesia pwede, no? Outpatient, okay? Usually about in a standard hospital, private hospital, about 5,000 excluding the PF, no? The professional fee, no? Okay. Now for the fine needle, probably mga 5 or 6,000, no? Private, no? For the core needle, probably 10 or even more, okay? Ganon, okay? So mas mahal, pinakamura dyan yung fine needle, di ba? Okay. And then availability, okay? So if you're in the province, fine needle will be the best available kagad, no? Especially if you are a GP, you can do needle biopsy. Then core, you need the instrument for that, no? Equipment. Then open biopsy, you need to do the incision. You must be, okay. Okay, so that's how you compare. Okay, then you tell the patient which one do you want, no? Okay. Now, indications, if you need, ang advantage ng core needle, you can get tissue. Fine needle just cells, cytology lang siya, no? Okay. So if you need tissue for biopsy, you want to have tissue diagnosis, and also you want to have some prognostic studies like ER/PR, no? HER2/neu, then you go for the core needle, no? So you consider the other factors, no? Kung kailangan mong added information, no? Kung hindi na kailangan yan, you just want to know whether it's cancer or not, you can do a fine needle biopsy muna, no? Then, if the plan is to do a open operation, let's say mastectomy, then after the mastectomy, you can have that specimen submitted for a ER/PR studies, no? Pwede din yun, no? Okay. So, yan ang decision making ng surgeon. Okay, how to check first on the indications and also the advantages and disadvantages of each, no? Okay, and of course the cost, but factoring in the cost and availability, no? Okay, so that's as far as the biopsy, no? Now comparing biopsy as a group and mammo and ultrasound, okay? Okay, so how do you compare the three? Talking to the layman. Miko, how do you talk to the layman? How do you compare the benefit of these three? Biopsy, tanggalin natin yung ultrasound guided. Basta biopsy in general, and then mammo ultrasound.
biopsy, mammo, tsaka ultrasound po.
Yeah.
So kung kakausapin ko po yung patient, sasabihin ko po na since ayun po i-explain ko po muna yung yun nga po yung in-explain niya na kung paano po ginagawa yung procedure. So yung ultrasound po, gumagamit po siya ng sound waves para po makita kung yung bukol po ay bukol po ba talaga o baka po ito lang ay cyst na meron pong cyst po kasi yun po. Tapos kung core needle biopsy naman po, yun po ay tutusok po tayo dun sa breast tapos kukuha po tayo ng
Okay.
tissue
Sige.
para
Can I cut you short
ah,
muna, ha? Can I cut you for the sake of time? No? Okay. Okay. After explaining the procedure, how do you compare the three now?
syempre po yung sasabihin ko po yung importance sa patient, yun po yung accuracy niya, yung cost din po niya, tsaka yung availability po nung
Okay.
procedure
So in
dun
terms of
sa
benefit, how do you compare the three?
ang pinaka-beneficial po sa case natin ay yung core needle biopsy po dahil marami po tayong info na malalaman doon. Tulad po nung yun nga po yung prognostic factors po.
Okay.
In terms of risk naman po, ang
Yeah, yung benefit lang. Focus on the benefit.
benefit.
Mammo,
Yun po.
anong
Yung
disadvantage ng mammo or advantage of mammo?
ang advantage po ng mammo ma-locate po natin yung mass and madedetect din po natin yung mga characteristic na imaging characteristics ng suspicious cancer like such as yung microcalcifications po.
Okay. Ultrasound.
Pero yung ultrasound po, advantage na non-invasive po siya, pero limited lang po yung info na makukuha natin sa kanya, such as yun nga po yung siguro makikita po natin yung size, yung border, tsaka yung contents po ng mass, pero hindi po tayo makakapag-provide ng definitive diagnosis from ultrasound lang.
Okay, so I'll give you some tip. No, I usually explain it this way. Now you put down the list, no? Biopsy, mammo, ultrasound, no? So simply sabihin mo lang kasi they just want to know this yung mga simple terms lang. Sabihin mo, yung biopsy among the three is the best because it's a direct exam. You get the sample, no? Direct exam yun, no? Yung mammo saka yung ultrasound, imaging lang yon, no? Indirect exam, no? Ganon, no? Okay? So it could be as simple as that. Maintindihan na nila yon, no? Okay? And then, okay, kung of course you explain the risk and the cost availability of the three, huh? Okay. Now for our discussions, okay, let's say a so-called community issue for discussions. Kasi in PGH, in UP College of Medicine, we also talk about yung mga community practice, di ba? Okay, relevance community practice. Okay. Yung mammo and ultrasound, ang naririnig natin palagi, mammo is still the best screening. Di ba? Okay. So, but I've not categorically heard of which for a diagnostic test. Iba yung screening, iba yung diagnostic. Diagnostic means may bukol na, no? Okay. So which one will be better? Di ba? Okay. Is it mammo or ultrasound? No? At the moment, the current practice is a lot of hospitals or institutions or the predominant teaching or practice among physicians, surgeons, no, OB/GYN. They usually order mammo and ultrasound together. Okay. Dati mammo lang, no? Before the advent of nauna yung mammo, naging popular yan history-wise, no? Then eventually pumasok yung ultrasound, no? Okay. So up to the moment, if you I don't expect you to know this, but just believe me, no? Yung mammo, once you get a mammo, they always put their BIRAD 0. No? Okay. At the end of the report, they always put the BIRAD 0 needs additional test. No? Okay. Meaning you have to go for a ultrasound. No? But for an ultrasound, bihira ka makakita ng BIRAD 0. So they stick to 1, 2, 3, 4, 5, 6. Diba? Okay? Okay, I'm telling you now because baka wala pa kayong masyadong exposure. No? Okay? So, kahit na yung mamo meron ng description, no, sabi ni Miko, no yung mga cluster of microcalcifications, nakalagay ito, no microcalcification, no skin changes, no thickening, no? Sasabihin pa rin nila, BIRAD 0, no? Because with those descriptions by itself, you can say BIRADs 1 or 2 or 3 already, di ba? Okay. So, naging habit na ng mga radiologists to put BIRAD 0 in practically all mammo. No? And then, the sad part is, we have a lot of mga breast cancer centers, tinatawag ng breast cancer centers na offer a lot of diagnostic tests. No? So, pumunta yung isang pasyente doon, nagpa-mammo, nagpa-ultrasound, no? Kahit na in the same center, kahit na done 1 hour after, no? Yung report ng mammo still 0, pero ginawa na yung ultrasound, no? The same center, no? So walang coordination among the radiologists, no? So kanya-kanyang basa, no? So dapat coordinated sila. If they really need the ultrasound, dapat i-integrate na nila yung dalawa, no? Okay? There are only a few centers who do that, no? Okay, i-integrate nila yung mammo, ultrasound. That is if they need the 2 tests together, no? To make a conclusion, no? Okay? So take note of that, no? That's why, as a matter of practice, I usually frown upon mammo. If there's a mass, I use a ultrasound na lang, no? Ultrasound, because I get more information or enough information. Okay. Ang information that you can get from mammo that will make you suspect malignancy will be speculations of the border. Diba? Sabi ko yung clinically dapat well-defined. Kung well-defined, medyo benign, di ba? Ill-defined, may speculations, di ba? So, mammo, cancer. Sa ultrasound naman, sasabihin nila, ill-defined border, di ba? That will be the basis for suspecting BIRADs 4 at least sa ultrasound. Ill-defined border. Na? Okay? Okay. So, any question about the ultrasound and the mammo? Kung ayaw ng pasyente yung biopsy muna, no? Kasi you can go direct to the biopsy even without the mammo and ultrasound, no? Okay, kung ayaw niya, then ultrasound niya muna, no? Okay? Okay, you have to adjust to the psychological makeup of the patient, no? Mindset nila, no? Okay? Okay, the approach and the diagnosis for this lab test, no, iba yung diagnostic test versus the screening for extent of the disease, no? So yung bone scan, you mentioned the one who presented the bone scan, liver scan, chest X-ray, and then I suppose the 2D echo is for the chemo, no? Chest X-ray. So to determine the extent of the disease, no? So you do that only once you have established a diagnosis of breast cancer, no? Okay. So yung diagnostic test, iba yon, ibang category, na like ultrasound, mammo, and biopsy. Diagnostic test for the cancer. Na the bone scan, liver ultrasound, chest X-ray, and others like yung ibang test, kung minsan may ginagawa silang test na alkaline phosphatase or yung mga tumor markers, those are the extent of the But in tumor markers, it's really for the diagnostic test, but usually it's not very reliable. No? Okay. So know the difference between the two. Unahin niyo muna yung diagnostic test. Once you have proven that this is breast cancer, then you can go to another set of tests, which is to determine the extent of the disease. No? Okay. But usually, pag asymptomatic ang pasyente, low risk for distant metastasis, you really don't need to do bone scan, liver scan, liver ultrasound, and CT scan of the chest anymore. Okay? Okay. Questions? Any questions? Let's go to the pre-treatment. So far, so good. Pre-treatment diagnosis. Okay. My comment here, you have to put the stage already. When you come to this point, you put not only breast cancer, no, you put the extent of the disease already, no? So that you can formulate your goal of treatment, no? Okay. In the goal of treatment, the first thing that you have to decide, is it palliative or curative? No? Okay. Although we never talk about cure in cancer, but we just use the word palliative and curative. No? Curative. No. Curative means there could be a good chance for cure, but we don't promise cure. No? Okay. Palliative, we accept that there's no chance for cure. No? Okay. Just to palliate. So this one, I suppose, just really for palliative goal. You all agree? So anong stage ito? Anong stage ito, Kenneth?
Stage 3B, sir.
3B.
3B.
Okay. Yung staging is before the chemo, ha? 3B.
Yes po, 3B POSI patient before chemo.
Okay. So wala pang evidence ng M, no? Wala pang evidence ng M metastasis,
Yes
no?
po,
So the
M0
staging
po.
should be before the treatment, no? Okay. Then after treatment, you can put a notation what after the treatment it became, ano, but you still stick to the original staging, no? Okay. So stage 3B, palliative nito. Okay. So the plan of the service is to reduce, patingin nga yung ano, goal of treatment ninyo. Althea, patingin nga yung, can you flash the plan of
Okay,
treatment?
sorry, looking for it. No?
The goal?
Goals of treatment. Here.
Okay. So the plan is to reduce the tumor volume and allow for definitive surgery. Okay. Then surgery. And then followed surgery. Okay. So it's a palliative goal, and then the specific plan will be to reduce the tumor volume, hopefully to allow surgery to take place. No? So the implication there is that surgery is still very important in the control of the cancer. Okay. Then after that, you can give other treatment, additional treatment post-op to reduce the risk for recurrence. No? So those are the goals. Okay. So in the neoadjuvant treatment, that's the first thing that you have to decide, no? Because that's the first specific goal that you want to do, to achieve. No? So, sino nag-present dun sa ano? Neoadjuvant options? Can you flash the neoadjuvant options? Okay. So, pre-op options is for the neoadjuvant, no?
Yes.
So, okay, you can, in the first column, okay, remember there are various regimens of chemo. Itong regimen na ginamit niya, doxorubicin and cyclophosphamide for four cycles to be followed by paclitaxel for 4 cycles, this is one regimen. This is considered one regimen. Then the other regimen will be the so-called CMF, cyclophosphamide, methotrexate, and 5-FU. And then there are others historical values, which I cannot remember. They can use AP rubicin and cyclophosphamide, okay, and also methotrexate. Marami pa yan, no? So, and of course, you added tamoxifen as another part of your, this is actually not part of your neoadjuvant chemotherapy, but it could be used as a pre-op options like tamoxifen and aromatase inhibitors, no? Okay. So yan i-compare ninyo, no? So in terms of comparison, okay, first the benefit, no? Yung benefit na yun, you can determine which regimen will have the best chance of decreasing the size of the tumor. Kasi yan ang objective natin, di ba? To reduce the volume. Which one will have the best chance of decreasing the tumor volume so that it can allow surgery? Di ba? Okay. So you have to look at the data, no? So I assume that since doxorubicin, cyclophosphamide, paclitaxel is very popular, probably it has the best chance. But you have to input also the CMF, cyclophosphamide, methotrexate, and 5-FU. Baka yung tumor reduction niya has a 90%, let's say probably, example lang ha, I don't have the data. Okay. So sabihin natin, 80% itong DC plus paclitaxel, and then for the CMF, it's about 60% or 70%, no? Okay. Pero in terms of cost, baka triple yung DC and paclitaxel, no? So you may input the okay. And then in terms of the risk naman, you don't have alopecia for CMF, but you have alopecia for doxorubicin, cyclophosphamide, and paclitaxel, and other complications and other side effects. Mas maraming side effects itong DC and P, no? Okay, and of course the cost, no? Mas mahal, no? And then for the hormonal therapy as a pre-op, again, during the pandemic, it was considered, it was the practice because patients cannot go for chemotherapy, no? So they just ordered tamoxifen or aromatase, no? So it could be done, but the benefit, the decrease in size, probably about 40% lang, no? At least it will decrease the size just to hold on until the pandemic is over, no? Okay. So, okay. So ito yung comment ko lang dito sa neoadjuvant treatment, no? And then so you jump to the post-op pain management. And post-op management ka na, no, before the surgery. Okay. Okay, this is another example of the use of the framework, no? So after surgery, so we have to consider the pain control, no? Okay. So the anesthesiologists and also the surgeons have different options. Now you can use the paracetamol plus tramadol, celecoxib, and others. Okay. So some would also still use paracetamol. Some would use NSAID. Now, okay, you can add more and then just compare. So which one will have the best chance of pain control among the four? No, kung sasama mo yung paracetamol and mefenamic acid. No, okay. So to consider, theoretically, if you go by the strength of the drugs, mas malakas itong dalawa, di ba? Paracetamol and tramadol, or even this one's the best, no? The strongest, no? Pero you have to consider how much is the pain that usually occur after a mastectomy, no? Hindi kasi nako-consider ng mga surgeon and anesthesiologists kasi parang dekahon na sila ngayon no? Okay. So if the pain is just less because when you do a mastectomy, you dinumb yung after you establish the flap or do the mastectomy, you cut a lot of nerves there. Usually numb na yan no? Okay, hindi na siya masyadong masakit, no? So you can use either paracetamol or mefenamic acid for the pain control kasi pwede na yun, kaya naman yun, no? So the administration of analgesics will be dependent on the usual pain that the patient will have after an operation, a specific operation, and also the pain threshold. Kung mababa ang pain threshold niyan, you have to give allowance for a greater or stronger analgesics, no? And of course, the cost. Okay? So mahal talaga yung celecoxib ang pinakamahal yata, no? Okay. Okay. Questions? Questions? Wala. And then going to the surgical treatment, no? Surgical treatment naman. So yung options, okay, theoretically pwede mong lagyan yung option, lahat possible options i-list down ninyo. But for efficiency purposes, sabihin mo kagad sa pasyente, and then after assessing her psychological makeup, napapayag naman siya na patanggal na lang lahat, you just focus on the things that are practical, no? Okay. Okay. So one will be a total mastectomy, no? And then with looking at the stage of the breast cancer sa kanya ngayon, baka nakadikit na siya sa pectoralis major, no? Then you have to consider doing a classical radical mastectomy already, no? To remove the pectoralis muscles and the axillary lymph nodes, no? That's one option. The other option, looking at the picture, mukhang hindi mo masasara yan, no? So you may have to put a skin graft after that, no? To close the wound, no? Malaking bukol niya, di ba? So pag tinanggal mo yung bukol niya, you're going to be left, what will be left behind will be a very large raw area which you have to cover with skin graft, no? Okay. Then the other option will be to do, if it's free from the pectoralis muscles, you can do a modified radical mastectomy, which is a total mastectomy without removing the pectoralis muscles plus axillary dissections, no? Okay. So yung breast conservation, like in her case, hindi mo na magagawa yan, no? Looking at the picture, no? So sabihin na niyo kagad sa kanya, no? Na since but kung yung pasyente nagtatanong, pwede pa bang ma-preserve yung breast, i-explain na lang ninyo, na? Okay, na hindi na kaya, na? Okay. Okay. Okay, going to the breast promotions. Okay. Sige, can you turn it off already? Okay, let's now go to the last topic. Any questions so far? Malapit na tayo matapos.
Sir, so dun po sa paper that we have to write, do we not include yung mga other surgeries na, bale, we don't compare the surgeries na po, or do we just not include yung breast conserving?
Ay, sa paper, okay lang sa paper, I don't mind. Sa ano, pero I'm just teaching you how to apply it in real practice.
And so in real practice po, you just tell the patient na mukhang MRM na po to,
Yeah.
or okay, sige.
Oo.
Thank you, sir.
Okay. If they ask, then you try to ask kasi they might know something about it. You just, okay. Okay. So even the reconstruction, you can say, kung batang, let's say, this patient wants to maintain her body image, no? Talagang obsession doon. Unahan mo na siya, no? I'm sorry, I don't think we can preserve your breast anymore, no? No? Unahan mo na lang, no? Parang for efficiency purposes, no? Kasi mahirap mag-discuss lahat eh. Di ba? Okay. Any more
Got it,
questions?
sir.
Okay, for the breast, palaging meron tayong after the operation, how to advise the patient, no? On prevention and health maintenance. Basically for the patient, yung surveillance, di ba? Surveillance for recurrence, no? Okay. So kung sa surveillance, you talk about two types of surveillance, which is not really practiced nowadays. Maraming ano. So first school of thought is tinatawag na symptom-based surveillance. No, you just base it on symptoms and signs, no, for recurrence. Then after, if kung merong signs and symptoms for recurrence, then that's the time you order some tests. No, okay. The other school of thoughts, you do a battery of tests every year, every 2 years, ganon. No. So when you say battery of tests, you do bone scan. Sometimes because of the popularity of PET scan, which is so expensive, no? Okay, palaging may PET scan na ngayon, di ba? PET scan, CT scan of the brain, CT scan of the chest, bone scan, okay? Abdominal ultrasound, no? Ganon, no? So you can imagine how much those things will cost, no? So you do it on a regular basis, no? First 2 years, pag hindi na kaya ng pasyente yung gastos, baka wala na. No? Okay. But the other school of thought is that you do it on the symptom and sign-based surveillance. You ask the patient, no? Meron ba kayong sumasakit ba yung ulo ninyo for a long time? Let's say for about 1 month, no? Okay. Kung meron, you start suspecting baka may brain mets siya, di ba? Then that's the time you can do a CT scan of the brain, di ba? Okay. You can ask another question. You ask questions based on the usual recurrence areas, no? Okay. So, meron ka bang palaging may bone pain? No, masakit ba yung buto mo, no? Okay. So, yung matagalan, ha? Hindi yung mga arthritis lang, ha? Okay. So, kung meron, then that's time you do your bone scan, no? Then you have frequent cough. Matagalan also, wag yung COVID cough, no? Okay. So kung matagalan, 1 month, 2 months, no? Then you do you're suspecting pulmonary mets, no? Then that's the time you do your chest CT, no? Ganon. Then the other one is you ask the question, abdominal pain, no? Or jaundice, no? Okay. To check for liver, to screen for liver mets, no? Kung meron, positive, may doubtful, then you do an ultrasound of the liver. No? Okay. So those are the 4 basic questions based on the common sites of recurrence of the breast cancer, distant recurrence. Okay. Of course, you have to ask the patients. Part of their preventive measures is promotion measures to do monthly breast self-examination. No? Pakapain nila. No? Okay. Once they detected something, report to you right away. No? Okay. Now, comparing the two, before I forget, no, School of Brain symptom-based survey, symptom signs surveillance-based surveillance, and the battery of tests, it has been shown that it's true that you will detect recurrence earlier if you do a battery of tests, kasi maraming tests, di ba? Na makikita nyo kaagad sa mga x-rays, ganon, no? Not things that you cannot feel, you cannot palpate, di ba? Okay. But when they die, because of presence of mets already, when they die at the same time. No? They usually die at the same time. Kahit na symptom-based or battery of tests, they usually die at the same time. There was this Swiss study on that. No? Okay. So, ang advantage ng symptom-based is that the quality of life before death is better. Kasi yung short time lang may anxiety, depression, di ba? Compared to yung madidetect ng early, mas mahaba yung may tatagal niya, pero they die at the same time. No? Okay? And of course, the cost, di ba? Mahal mga for the battery of tests. No? Okay. So my practice, I usually use symptom-based surveillance, but of course, I tell the patients about these 2 options, then let them decide. No? Okay. So most of the time, they go for the symptom-based, as long as they do the breast self-examination and the clinical examination by you, no? By me, no? Ganon, no? Okay. So as to the relatives, of course, you have to extend it to the relatives. Yung So ang common questions is, do they need mammography, ultrasound, ganon, mga relatives, no? So kung merong breast cancer, okay, number one, you always advise them do breast self-examination, rely on breast self-examination. Kasi mammography ang daming false alarm din doon, no? Okay. Teach them how to do breast self-examination, no? Kung talagang gustong-gusto nila, make sure that they do it on the anong age i-recommend natin ngayon. We can see in the chart percentage. Siya ba nag-present noon, yung last one?
Me, sir. Age 40, sir.
Age 40 for those with family history.
Yes, sir.
Without family history, yung sa Europe, 50 and above, di ba? Iba-iba,
Yes.
di ba? Okay. So, magulo, di ba? So, okay, kung but you tell them the options. Baka pwedeng breast self-examination na lang, no? Monthly. Turuan na lang ninyo, no? Make sure they do it, no? Kasi ang disadvantage ng kahit na magpamamo ka, kung nagpamamo ka ngayon at age 40, negative lumabas, ang next mamo mo will be next year, di ba? In between, lalabas yon yung bukod mo, di ba? Na you'll be missing it, no? Kasi hinihintay mo yung next year pa, di ba? Whereas when they do their monthly breast self-examination, makakapa nila agad, no? Even without waiting for the next schedule for mammography, no? Okay? Okay. So I think that ends our complete explanation or detailed have expounded on the framework, no? So any questions?
Sir, question po.
Sure.
Sorry.
Nicanor.
Hello, rinig po ba ako?
Di kita nakikita.
Sorry, sir, hindi po kaya ng internet ko.
Okay. Hindi kita makita yung mukha mo. Okay, sige. Okay lang, sige.
Sir, so yung paraclinical diagnostic tests, different pa siya with the diagnostic tests.
Yeah.
Tama po ba?
Tama. Yung para is after the clinical diagnosis.
Okay, sir. Okay, sir. Tapos next question, sir. Yung for the paper, sir, ano po yung magiging parang assumption namin? We assume ba na no workups done pa sa patient or do we go with the current presentation ng patient na may history na siya of chemotherapy, of biopsy, with all the workups na? Para lang po clear lahat.
Again, sorry. Ulitin mo nga.
With the paper po, do we assume po ba na wala pang workups na nagawa sa patient? Like, similar po sa SGD natin? Or do we go po with the current presentation ng patient na may workups na, may chemotherapy na, and for surgery na po?
That's a challenge na tinatanong sa akin ni Kenneth, di ba? Kahapon, no? Okay.
Yes.
And then, okay, ganun na lang. Don't be worry about yung paper na lang. What's more important is that you learn from the discussions. Okay? Okay. Ideally, dapat, number one, kasi I've been teaching problem-based learning na yung from the very start hindi yung alam, no? Then you proceed all the way step by step up to the end, no? Pero kung minsan, kung may mga diagnostic test na nagawa, no, and you get this patient in the middle of the treatment, no, okay, i-comment na lang ninyo, no, you can see what should be done and what should not be done, ideally, gano'n, no, i-comment na lang ninyo, no, okay. Kasi different doctors have different approaches. We can never be uniform. There's no one way of doing things. We cannot really demand all these doctors to do the same thing, no? But at least the process pwede, di ba? Do you agree? Can we agree on the process? This is probably should be the first clinical practice guideline, just using the process. No, clinical practice guidelines, they dictate on you what medicine that you should give, what you should do, no? Pero it all depends on the patient, di ba? Okay. Yung tinatawag na patient-centered management. It depends on the situation of the patient, the mindset, no? Yung, economic situations, etc. Di ba? Okay? Did I answer your question, Nicole?
Sir, she said yes daw and thank you daw for answering her question, sir.
Bakit ka sumagot?
Sorry, hindi daw maka.
Okay. Okay. So any more questions?
Tama po ba, Doc? So, di ba kanina we mentioned na given yung pattern recognition nga ni patient, medyo masasabi natin na sa may high 90s na yung probability na breast cancer talaga. Given that, nasa certain area na siya, so hindi na po kailangan, tama po ba, ng para-diagnostic test?
Pwede. Speaking,
Para clinical.
yeah, speaking pwede. Kasi clinically 99% and the treatment probably if it's the yung probability is 1% lang TB, no? And TB can also be treated by total mastectomy, no? Okay. So basta you can explain this to the patient properly, get their informed consent, no? Okay. In fact, this Saturday, I'll be doing a total modified radical mastectomy in PGH. The patient does not want any biopsy. Okay? Okay. I am 95% sure it's breast cancer. So I told her option is to do a biopsy before I remove your entire breast. No, but she said, no, I don't like to do a biopsy. Just proceed to the total mastectomy. Okay. There are some patients, okay, as physicians do not insist on what you should be doing, no, you have to give some allowances. There are some patients who believe that once you touch the tumor, they will spread. No? Okay, tandaan niyo yan, ha? Marami pa dyan, ha? It's a myth. Theoretically, it's possible, but very rare, 1% lang. Kasi no such thing as zero, di ba? So 1% lang. No, but a lot of Filipino patients, or even abroad, if you look at the literature, they still think that once you touch the tumor, it can cause it to spread rapidly, recur. No? Yeah, there are some patients, pag in-insist mo, iba-biopsy mo, pupunta sa ibang doktor na yan. No? Okay. So you just get an informed consent, let them sign. Okay, parang waiver. You refuse to do a needle biopsy, you just sign it. Okay, we'll do it. No? Okay? Pia, okay lang?
Yes po, thank you.
Sino pa hindi nagsasalita rito? Wala na. Althea, any question? Althea, the leader.
No na po. Thank you so much.
Okay. So wala na.
So we have one last question lang po.
Sure.
Just in practicality, for practicality's sake po, when do you want us to submit the paper po?
When?
Po. Or by when do you want us to submit it po?
Okay,
Additional.
as you presented it, okay na yun. Wala
Sorry.
pa ba? PowerPoint lang ang ginawa niya?
We haven't started on the paper po. Pero we're asking if when we can submit the paper and what should be part po.
Okay.
And how we're gonna submit.
Kayo, when do you want? Kasi I thought all the while last day na niyo today eh. Kaya pinilit ko yung isingit ko lang kayo. Kayo, tomorrow? Wag na yung i-delay para patapos na kagad. Di kayo makasagot.
Wait lang po.
Busy kayo?
Okay daw po yung tomorrow. Tama.
Tomorrow. 1 week pa ba
Okay.
kayo sa surgery? 1 week?
Yes po. Next week pa po yung last namin.
Tomorrow. And then make sure to submit yung olete, na? Those who did get a perfect score, try to get a perfect score para I can give you a bonus point, no? Mas malaking bonus point. May bonus na yung mga yung not the perfect score, no? Mas malaki yung bonus points yung perfect score, no? And then also your feedback to the faculty. And after that, can you give me Althea? Can you give me the
Yes po.
students evaluation, yung guide.
Okay.
I have to submit grades, right?
Yes po.
Bigay mo din sa akin, ha? Okay?
Then I submit the paper directly to you na lang po. Can I get your email?
rhoson2001@yahoo.com.
Thank you po. Do I submit just the paper and the students evaluation guide po? Do I have to give proof po about yung olete? Or okay na po?
Yung olete, I'll be the one to look at the, at the
Okay.
score. Diba?
Okay
So
po.
you just submit your paper and then yung form for the student evaluation so that I can fill it up, no? And then you have to submit your faculty evaluation also. Okay? Tama?
Okay.
You have to evaluate me. Right?
Okay po. Thank you.
Okay. So before we leave, can
Oh,
we-
sir. Yung post-op interview po ba? Pag kasi should it be part of the paper pa po?
post-op?
Yes
Oh.
po. Kasi today pa yung operation ng patient.
Wala na. Sige, wag na lang. Wag na lang. Wag na
Okay.
lang. Okay. Okay.
Okay po. Thank
Anymore?
you.
Picture muna tayo. Can you take a picture on your
Okay
side?
po. I'll take the pictures.
Nako,
Okay,
hindi kasama
one.
si Nicanor.
Ay,
One.
Nicole, can you try? Kaya ba? Edit lang natin. Kaya
One.
ba, Nicole?
Ayan,
Ayan.
ayan. Ayan, one.
2, 3, sa. Honor. 1, 2, 3, sa. Thank
Okay.
you.
Sige. We'll
Yes,
see you
sir.
see each other in Manila. Bye-bye.
Thank you so much
Sige
po.
po, ingat po
Thank you so
kayo.
much, sir.
Ingat po kayo.
Bye-bye.